This is one of the more challenging situations we've been trying to find a solution for, which is how can we get to ovarian cancer before it actually becomes a deadly disease. So I will just start out my talk with talking about a little bit about background for ovarian cancer. It's the deadliest form of gynecologic cancer we have. Most of the deaths in the U.S. From gynecologic cancer come from ovarian cancer. And as you can see, there's about 20 to 25,000 cases a year. And unfortunately, the great majority of these patients will die from their disease. The lifetime risk is not that high, and the order of importance is probably anywhere between 5th and 7th leading cause of gynecologic leading cause of cancer in women. And so 1 in about every 60 women will get ovarian cancer during her lifetime. Most of these women are older. Most of them are over the age of 50, typically in that 5th to 6th decade. If we are able to find ovarian cancer when it's really early, when it's still confined to the ovary or has not spread to any surrounding organs, then the survival is excellent. Typically, survival rates can go over 90% with aggressive surgery and chemotherapy. Unfortunately, once the disease spreads, that survival goes down and plummets. And you get to a point where most patients who are either stage 3 or 4 will actually succumb to their disease because it will come back and spread and become resistant to traditional treatment. Most of our patients, unfortunately, at this point are diagnosed when the disease is already spread. 3/4 of our patients will be diagnosed when they are stage 3 or more. These tumors almost always come from the surface of the ovaries, which accounts for most of these patients. And interestingly enough, even though we've come up with all these compounds and advances in surgery and radiation and ways of delivering different drugs, we haven't really been able to change much in terms of the needle when it comes to mortality from ovarian cancer. Despite all the advances we have in delivering these drugs and newer drugs, we haven't really been able to make much inroads in terms of mortality. We still also don't really know how ovarian cancer starts and how it spreads. There may be multiple ways that these tumors arise and spread, and it could also account for the reason why it's such a varied disease. When we try and analyze these tumors, we always find that the way you got to the cancer is a myriad of different ways and not just one way. This is a slide that goes over some of the risk factors. I'm going to point out the most important ones. And by far the most important one is family history. You'll notice that having one relative, particularly a first-degree relative with ovarian cancer, will triple your risk of ovarian cancer. Okay, so family history is really very important. And especially when you're looking at familial ovarian cancer, and that includes gene mutations that lead to ovarian and breast cancer. There are also familial syndromes that are not necessarily linked to gene mutations that we know. But for these patients who have extensive family histories of ovarian cancer, the lifetime risk can be up to 50%. Okay, so family history is by far the biggest risk factor when it comes to ovarian cancer. So as you noticed, I mentioned that screening or that if you find ovarian cancer at an early stage, you are able to save a lot of these women. You're able to cure them of their cancer. Whereas if you find it at a late stage, it's often too late, and very little of what we have to offer in terms of treatment can reverse the process. So it presents an opportunity for screening, especially if you're looking for early stage disease. And this is sort of a set of guidelines that WHO put out back in the 60s that still applies today in terms of what screening should achieve. So screening should be for a health problem that's a serious health problem, and obviously ovarian cancer is. You should have effective and applicable treatment. If you can detect a medical problem to which there is no cure, then there's really no role for screening. So obviously it's more important for you to detect ovarian cancer at an early stage where your treatments are much more effective than when it's late stage. You should also find it preferably at a point where the patient is not symptomatic. If a patient comes in with symptoms, you're not screening them, you're basically diagnosing them. Screening is designed to look for patients who are without any symptoms. And this also indicates that you're finding it at a point where it's small enough not to cause symptoms, but also easy enough to treat. The tests that you should offer for these, the screening tests, should be acceptable. It shouldn't be something that is so onerous or taxing on the patient that few patients will go through it. It shouldn't be a very expensive test. It should not be a very painful test. It should be a test that most patients or potential patients should accept. And you should be able to apply this across the board. If you only have 1 or 2 centers across a country that could do the testing, you can't really scale that up. You have to use something that's readily available to the biggest number of potential patients around. And obviously the cost to benefit ratio should be promising. So what have we tried to look at so far? Because we've been trying to resolve this problem now for a number of years. So what have we tried to achieve in terms of ovarian cancer screening? So in the past, we used to rely a lot on physical exams. Unfortunately, physical exams are notoriously bad at detecting ovarian cancer when it's at an early stage. So the GYN, or the annual gynecologic exam, has not really made much inroads in terms of being able to help us detect ovarian cancer when it's still in an early stage. Other routine tests that we offer most women when they come in for their annual exam, say like pap smears, are not very effective at detecting ovarian cancer. So sensitivity indicates the percentage of actual ovarian cancer cases that you can detect using a test. And you can see pap smears are really pretty bad. So they were never designed to detect ovarian cancer. And when we tried to apply that to ovarian cancer patients, it wasn't really very successful. So what we've tried to concentrate on more and more as the years went on are blood tests that are very particular to ovarian cancers, as well as imaging that looks at the ovaries much more carefully, and then a combination thereof. So the blood test I will be mostly concentrating on is what's something called the CA-125 blood test, and that refers to cancer antigen 125. Ultrasonography, I'm referring to pelvic ultrasounds, so ultrasounds that are designed to look into the pelvic cavity of women, usually transvaginal ultrasounds. And then multimodality screening is sort of a combination of imaging and blood work. So what about CA-125? This is a glycoprotein, so a combination of sugar molecules combined with protein that's present on the surface of most cells that line the inside of the abdominal cavity. Now, for some reason, when you look into the blood of women with ovarian cancer, you can find pieces of this antigen at much higher levels than you'd anticipate. So 80% of patients with ovarian cancer will have an elevated level of CA-125 in their blood. The problem with CA-125 is when it comes to the early phases of the disease. When we looked at normal levels and when we looked at patients with various stages of ovarian cancer, we frequently found that patients with early stage disease had CA-125 levels that were still within that normal range we expect. It's only when disease starts to spread that the majority of women will have an elevation in the CA-125. So that sort of limits the sensitivity of the tests. But also, there's a lot of other conditions that many women have that are not cancerous that could trigger an elevation in the CA-125. These are so-called false positives. So you have an elevated level and it turns out to be something not cancerous. For example, fibroids or conditions even as benign as a menstrual cycle in women who are young enough. So that sort of limits how the specificity or how accurate the disease is. In the past, we used to look at just a single measurement of CA-125. So we took just a snapshot of the blood and decided to see if that snapshot was enough to detect ovarian cancer. Unfortunately, what this ended up showing is what we call a very poor positive predictive value. So what that basically means is if you have a test that is considered abnormal, what are your chances of having the condition you're looking for? Okay? And that turned out to be about 4%, which means that for every 100 patients who get an elevated level, only 4 of them will have the condition you're looking for. That means for the vast majority of these patients, you get anxiety, procedures, unnecessary testing that is not called for. And when we found that, this was obviously not something that's acceptable to most patients. We're going to harm a lot of patients in order to save a few. So it didn't make a lot of sense. So what people tried to look at was, so why don't we follow it over time? And this was sort of pioneered in England, where they started to look at the trends of CA-125 over time. And you'll see this is from an old study from the early 1990s conducted in England, where you can see that the patients where you see a steep rise in the CA-125 are those patients with ovarian cancer. And some of them started in the normal range and then went up very quickly. So these are patients where if you looked initially at just a single measurement, you would never have detected the ovarian cancer. You also see patients where the levels stay high but are stable over time. And these patients have falsely elevated levels. And you can see that these patients would have been labeled as potential ovarian cancer patients without really having the condition. So we started thinking that maybe following the CA-125 was a better way to try and detect ovarian cancer in these patients, because the dynamic changes are much more informative than the actual test itself when you just take a snapshot. This is a slide showing how much more accurate and sensitive the trend is, as opposed to just looking at a single measurement of the CA-125. So the problem still lied in the fact that you were still missing some patients. We still could not get to the point where that positive predictive value was good enough for us to be able to use that test as a regular screening test. So people decided to look at other molecular markers or other blood markers. Ones you've probably heard, you may hear about are HE4, and then panels of different tumor markers. These are all designed to be better performing than the CA-125. Unfortunately, none of them turned out to be better than the CA-125. So a lot of the initial excitement about these tumor markers sort of died off very quickly when we found out that this was no better than what we already have. Back about 8 or 9 years ago, well, it was in 2005, so almost 10 years ago now, some researchers out of the NIH came up with a molecular profile that could, or a sort of a protein fingerprint for ovarian cancer that they felt could indicate really early stages of the cancer before patients even became symptomatic. And they put that together as something called OvaCheck, a protein profile of the blood. The problem with that is once we tried to apply it in real life to real patients, it did not end up working. It was no better than flipping a coin. We've been a little bit more successful in terms of being able to detect ovarian cancer by using a panel of markers called OVA1, and some of you may hear that. It's still not completely validated and has not proven to be more beneficial than the CA-125. And you'll notice it even incorporates it into its panel. And this is part of some of the tests that physicians can send, although it's not endorsed by our official group and has not been used in a screening environment. So what about ultrasounds? Ultrasounds are the second modality that we've used to try and detect ovarian cancer. You don't want to use a lot of radiation to expose many women to unnecessary radiation. And ultrasound is a fairly safe and innocuous method to image the ovaries. You're obviously, if you put the transducer through the vagina, you can obviously get really close to the ovaries and can really image them very well. The problem with ultrasounds is they are also plagued with the same issues as CA-125. Many things that look abnormal on the ultrasound do not turn out to be ovarian cancer. And you sometimes frequently miss ovarian cancer on ultrasound, especially when it's in its early stages. So because of the limitations of both the blood testing and the imaging that we've encountered, a lot of people moved very quickly toward trying to combine both approaches. Let's put the blood test and the ultrasound together in a variety of different combinations. Initially, in the UK, which was a lot more cost-conscious than the US and Japan, they decided to start with a blood test. If the blood test was abnormal, then you would get an ultrasound. And in that approach, which was back in the early 90s, they basically found that when you screened women with yearly CA-125 in that very early trial, and if that abnormal level of the CA-125 then triggered an ultrasound, you could then detect a lot more ovarian cancer without doing a lot of unnecessary surgery. So instead of going from every 40 or 50 patients being screened and operated on to find a single case of ovarian cancer, you now go to every 4 patients being screened and screening positive for the test and for us to find a single ovarian cancer patient. So that translated into a much higher positive predictive value, which was very encouraging. This was not the end-all be-all in terms of testing, but it was encouraging in terms of us being able to detect the cancer without incurring a lot of harm. Unfortunately, in Japan, when they tried to do a similar trial, they were not so successful. In that trial in Japan, they basically subjected all the women that enrolled on the trial to both an ultrasound and a CA-125 at the same time. This is different than what they proposed in England, where you started with a blood test and then got an ultrasound. In Japan, everybody got an ultrasound and everybody got a blood test. And you'll see here that it took for every 33 patients that got a positive result either on the ultrasound or the CA-125 or both, you would find a single patient with ovarian cancer. So a lot of patients who get unnecessary treatment, unnecessary anxiety, unnecessary false results. We tried to replicate what the English were doing in terms of screening here in the US as part of a very large trial called the Prostate, Lung, Colorectal, and Ovarian Cancer Screening Trial, the PLCO trial. This was a very large NIH-sponsored trial that started in the 90s, extended into the 2000s, looking at screening methods for some of the major cancers in the US: prostate, lung, colorectal, and ovarian cancer. And in that trial, there was an arm devoted to ovarian cancer where they screened women in a way similar to what the UK did. The problem is all these women, just like in Japan, had an ultrasound and a blood test as well. Whereas in the UK, you always had a blood test first and then an ultrasound if the blood test was abnormal. As a follow-up to the previous English trial, the National Health System in England commissioned a larger trial looking at many more women, almost 250,000 women, to undergo this series of testing with a blood test every year. And if there was an abnormal level that was triggered, then get an ultrasound. And that was called the UKCTOS trial. And the results of these two trials were published almost simultaneously, and there were almost exact opposite results. So in the UK trial, they screened over 250,000 women, about a third of the women had usual care, which is just your annual exam and pap smears, just like you did before. About half of these women had the blood testing followed by an ultrasound. And then the other quarter of these patients had actually just annual pelvic ultrasounds. Okay? What they found was for those patients who had the multimodality screening, so the blood test followed by the ultrasound, they were able to detect an ovarian cancer for every 3 or 4 patients who tested positive. So a much higher positive predictive value. But more importantly, most of these patients, a great number of these patients had early stage disease, which we were never able to show before. And this was very promising. So one, you detected, you didn't have a lot of false positives, so not a lot of women had to go unnecessary testing and surgeries. But also for those women that tested positive who were found to have ovarian cancer, these patients tended to have earlier stage disease, exactly what you were looking for. Now, in the US, unfortunately, this did not turn out to be the case. So in the US, unfortunately, there was a lot more false positives, and most of these patients, when you did detect the ovarian cancer, it was already at a late stage. So not unlike what we already were finding in our patients who were not screened. The difference here is obviously the fact, a lot of people pointed out that the difference here is obviously the fact that in the UK, you started out with a blood test and then got an ultrasound, and in the US, you got both at the same time, so more opportunities for false positive results. Also, the ultrasounds tended to show things that are abnormal, which in the UK would be disregarded as abnormal, so these are some of the subtle changes that they were able to detect or between the two studies. But because of these contradictory results, nobody really has a final answer in terms of whether or not this screening method works. The other big issue, which the UK trial, even though it was very promising, and even though the follow-up results seem to be very promising, we don't have data from this trial that shows that this actually saves people's lives, okay? When you look at mammograms, when you look at colorectal screening, when you look at pap smears, these successful screening methods, you'll notice that you can save lives by doing that. When women get mammograms done when they're 50 to 60, you can save people's lives doing that. Same thing with colorectal screening. Same thing with pap smears. We have not been able to show that with this type of screening. Even though it looks very promising, we don't have that data back. So just to finalize things, I don't want to spend too much time on this. Because of the contradictory nature of the results, particularly from the UK and the US, we still do not have a consensus in terms of screening. We cannot recommend that for anybody in the US. Also, you have to understand in England, they use a very proprietary algorithm to trigger the positives. So we don't know what makes somebody CA125 abnormal in England. They still don't tell us the exact details about how they consider something abnormal, because there were some results in England for some women where you could have normal levels of CA125, but that would still trigger an additional test. And we don't know exactly which threshold they use and what are some of the mechanisms they put in place to trigger these results. So that still is not out there. So we can't really recommend that especially for average risk women. Now, when we have patients who have familial syndromes or have a very strong family history, these are patients which we offer screening to without any real data. That's a different problem altogether. For these patients, we do offer screening with ultrasounds and blood tests, which we can't really back up with any data, but we do it because they are at such high risk, with the understanding that we may not be able to find their tumors at an early stage. And so for many of these women, we offer what we call risk-reducing procedures, where we remove the tubes and ovaries to reduce the risk. But that's a very different population than what we look at when we try and look at the entire general population. Okay, this is just sort of a guidelines for the physicians to refer to a GYN oncologist. Doesn't really apply so much for screening. Thank you very much.
Any questions about this material? Good. Start here.
Oh, sorry, are you talking about
any one of the three?
I have a question for Amr. What are your thoughts about the fallopian origin of ovarian cancer?
It's been actively debated. There's speculation that probably maybe even half of the ovarian cancer cases that we detect have an origin at the fimbriated end of the fallopian tube. It's still a matter of debate with the percentages, if there is really a percentage there. Again, like I said, one of the biggest mysteries that plagues us in terms of ovarian cancer is the natural history of disease. We can't really put our fingers on how these tumors develop. It may be that there's multitude of different ways that they develop, either within a cyst or on the surface of the ovary or within the fallopian tube. and we just have not been able to completely elucidate that. So that's the impetus behind some risk-reducing measures in terms of trying to reduce the risk of those patients who are at highest risk for ovarian cancer without having to remove the ovaries by removing the fallopian tubes. But that's still obviously an unanswered question.
On the histopathology, is P53 still the best analytic tool?
Well, it's not a universal mutation, and it depends on the type of ovarian cancer or even epithelial ovarian cancer that you're looking at. So, for example, you know, some of they just like they do for endometrial cancers, there's now like type 2 and type 1 epithelial ovarian cancers. Some of the less common types, say like low-grade serous cancers and borderline tumors, and some of the non-serous histologies don't always carry P53 mutations. So it does not always correlate very well. And, you know, people look at, well, there's a P53 mutation. I mean, if you look at immunohistochemistry, it's all over the place. It could be from complete absence to an overabundance of P53, of sort of null protein, for example. But again, nobody's sort of standardized that.
Other questions? Dan?
As long as we're having sweating a bit, Dr. Goff has popularized a symptom index. It turns out that most ovarian cancers are not silent. Even early stage ones, and up to 80–90% have vague symptoms. Is that being integrated at all? Although it's not screening because they're already symptomatic, but using that to maybe prompt more direct measures, such as if you have this symptom complex, get a CA-125.
Sure. I mean, people have tried to do that. Obviously, this is not to do with screening. This is more a diagnostic approach. But Barb really has been pushing for that. The problem is none of the data really backs it up. Interestingly enough, in England, the NHS has popularized, especially amongst its primary care provider, a questionnaire that will give you a risk. It's available online, anybody can do it, but it's a questionnaire that patients can answer electronically, and it'll then flag these symptoms to the primary care provider, who could then initiate the proper referral based on their sort of review of the data. The problem is when people looked at that in patients in Australia, where they also have a sort of a similar looking or similar type of health system, when they looked at retrospectively at their patients and looked at symptoms and onsets of symptoms, it didn't really matter whether these patients were seen within a week or two after their symptoms started to be noticeable, or 3 months later. The outcome was the same. The same proportion of patients with advanced stage ovarian cancer, same proportion of patients cured or recurred or died. Unfortunately, in most cases, yes. It's just not. I think most of us hold a lot of more promise for screening because you're detecting it at the asymptomatic level. And I think that's, you know, what most screening looks for, whether it's cervix or colorectal or ovarian or breast.
I think in the back there. Yeah. Yeah.
I was wondering, from what you said about the CA-125, that wouldn't it be advised that women as of a certain age, when they go for their annual shoot, be tested for the CA-125?
Well, you know, that's still not been established. One, you know, like I said, we still have to refine how to interpret the data. A lot of the time, if we just take a single snapshot, like I said, you miss a lot of things. You also get a lot of false positives that could trigger a lot of unnecessary testing. For example, in the PLCO trial in the US, when they just looked at the CA-125, there were like 600 patients who underwent surgery. You know, more than 400 had unnecessary surgery, and a few patients died. So we can't really I can't really recommend that quite yet. The problem also is interpreting what happens later on. Say, for example, you forget what the number is, and you just use it as a baseline. How do we interpret it compared to the following year? When do we initiate these triggers? So the problem with the UK CTOS trial is they have somehow found a way to do that, but they're not telling us what the recipe is. Okay, they're not telling me, okay, so if it goes up a couple of points, is that bad or is that good? I don't know. If it goes up 20%, is that bad or is that good? I don't know. If it goes down, is that a good or a bad sign? We don't know. So unfortunately, I cannot recommend that. People also have to realize the test itself is not uniform. You go get a tested here and then you go to your local lab. It's going to change a few points, and that may be an issue.